Hello, welcome. I am Stephanie Talabasa, the host for today's payment panel discussion on behalf of the APTA private practice section. As we're getting settled, check that your name is listed under your picture and turn your cameras on because this is going to be an interactive discussion. I will ask you to stay on mute until it's time to jump in, but please turn the cameras on so we could see who we're talking to. Don't think of this like a webinar. This is not something you're going to passively listen. I want you to have a chance to ask all of your questions, participate throughout the discussion. And if you are multitasking, put your questions in the chat because I'll be asking them on your behalf. First question in the chat. How many people here watched the strategic contracting series? Just yes or no in the chat for me. I watched the first two modules myself, and I was definitely taking notes and kind of wishing I could ask questions in the moment. So that's what we're going to do today. So knowing who has watched it is helpful. Little housekeeping. Later today, you're going to get an email with a feedback survey. I personally read every response and take that into account as we're shaping the next event. So if you were here in January and February, you might already notice that this format is a little bit different. So please just take a minute to fill out those surveys. Okay, I see a few more people entering. So again, I'm Stephanie Talabasa, owner of House of Physical Therapy in New York City, and we have a guest panel with Mike Horsfield, Kelly Sanders, and Bob Hall. In a moment, I'll let them introduce themselves. First, I want to get to know who's in our room. So either type in the chat, or if you feel comfortable, you can unmute and share the reason you signed up. And one thing you could leave with today that would help you the most. And if you're not sharing that, please mute. So I'm going to put that question in the chat and I'm going to give everyone a minute to answer. I know it takes a second to type, so feel free to just come off mute and share. I'm putting my answer in. So I'm here because I want to be informed on what's going on. I want to know what's happening behind the scenes and in the rooms that I'm not in. And as a small clinic with 8 employees, I want to know what we can do specifically. So just throw your answers in the chat. And if anyone feels compelled to share out loud. Okay, so we're interested in contracts with employers. Kelly is definitely going to touch on that. Anyone else? Okay, how to deal with big insurance. Any information on payments? Yes. The more informed you are, the better. Great. All right. So I'm gonna, while everyone's putting their questions in, I'm going to allow our panel to introduce themselves. So Bob, why don't you come off mute and introduce yourself first?
Great. Well, thanks so much for the opportunity to be with you all today. My name's Bob Hall, and I've worked for the section for, coming up on 5.5, 6 years. And we've been focused on payment advocacy, trying to produce resources and other materials for you all. I came here after working as the office lead for the American Academy of Family Physicians for 3 years. And then prior to that, 10 years as the lead access lobbyist for the American Academy of Pediatrics. Recovering lawyer. I also was a counsel to a senator in the United States Senate for a few years when we passed Medicare Part D. But I've been doing this stuff for 20, 25 years, and it's just great to work with you guys. You guys are the white hats, and I hope you can remember that. Everyone is with you. They want you to be able to succeed in this area.
Okay. Mike, you want to go next?
Sure. Hi, everyone. I'm Mike Horsfield. I have the pleasure of serving as your current APTA private practice president. My day job is CEO of Rock Valley Physical Therapy. So we're a multi-clinic, a multi-site practice, physical therapist owned in the Midwest with clinics in Iowa, Illinois, Nebraska, and South Dakota.
Okay, Kelly.
Hi, my name's Kelly Sanders. I also have the opportunity to serve on the board for private practice section. In my day job, I am president of Movement for Life PT. We do outpatient physical therapy in a few different states, and that's my main role. The other thing I do on the board is I'm the liaison to the payment policy committee that also puts together a lot of resources to serve the section.
So Kelly, I'm going to stay with you for the first question. Let's just get right into it. How can individual clinics contribute to advocacy efforts?
Sure. So I think the word advocacy is one that sometimes we make the assumption is federal advocacy going to hit the Hill Day or going to your state house and doing that very important form of advocacy in terms of meeting with legislators, which definitely don't want to take away any of that. Those are really important things, and we always want physical therapists to go meet both in their communities and in their state capital and in Washington, D.C. with their elected officials. But I think sometimes we forget the other forms of advocacy that we can do as practices. So my probably big one is really being aware of the contracts we take and not signing bad contracts. That is one way to advocate for our profession. And then another one, I think someone put it in the chat somewhere, and they talked about, or I think you mentioned it, Stephanie, were takebacks or appeals processes, things like that. Those are forms of advocacy. When we don't just accept that an insurance is going to take back money or going to deny our services, it's really important for us to appeal those denials and make sure we're advocating for the services that we provided and the value of our care. So advocacy spans a lot of different things. And I think thinking about those things is really important. I think to think of advocacy as anything that promotes our profession or that educates other people outside of our profession, our patients, our families, on what PT does are all really important forms of advocacy for our profession.
I think that point of thinking about it in a non-traditional sense, and what can you do internal is really a big mindset shift.
Yeah, I think sometimes it is we forget some of the things we do every day or don't do every day because there might not be a cost benefit to it. We forget that they're advocacy things. And on the formal advocacy front, here on behalf of PPS or private practice section, please do check out the website. There are lots of great ways to get involved in formal advocacy, whether it be our Key Contacts program. There's lots of training and education on how to become a key contact, how to work with and advocate for the profession with our elected officials as well. So definitely don't want to take away from that component. And we welcome any involvement. And please reach out if you want to find out ways to advocate for the profession. We love to have people join in that battle.
So this one will be open to anyone on the panel. One topic that came up multiple times is contract negotiations. So maybe let's go to Vicky if you want to come up and ask your specific question. If not, I'm just going to let, let's say, Mike, what would we address with contract negotiations with the insurance companies?
Yes. So I think if we're discussing kind of commercial, Vicky, and please feel free to jump in here if I'm not addressing the question in the right manner. But I think with any negotiation, right, the question always is who has leverage in the conversation. And so leverage is defined. I think the best definition I've heard of leverage is he or she who's got the least to lose from walking away from the table has leverage in the negotiation, right? So that. So when you look at your contract negotiation, I think that's what we're trying to do with the Smart Contracting series is really educate people on how can you quantify what I have to lose if I walk away from this? Because what I believe and Bob, I'm going Bob and I play this game where I say ridiculous stuff and then Bob corrects me and tells me that's not right. So we'll play that game in front of you guys. I don't believe insurance companies care about quality. Okay. I don't believe they actually even care about cost. I think what insurance companies care about is making money. And so I think when we're having conversations with payers, we sometimes use words like, well, we're really good quality and blah, blah, blah. And I just don't, they give it lip service. They talk to us about it. They kind of keep us distracted by that shiny object. Or we talk about cost savings and they'll entertain that. But I've yet to see any insurance company do anything at scale around kind of quality and cost in the PT space. They've done some pilots, some trials, but they've always been short-lived and kind of went away. So I do think what they care about is their ability to sell insurance in the state, which is called network adequacy. They have to have enough providers in an area to sell insurance. And so if you have a large practice, you might have some leverage by taking all those clinics out. But even for us, I'm not sure we are even big enough to do that, right? So then it's just a game of chicken. But I think rather than it being a game of uninformed chicken, I think that the key for you guys is to look at it and say, know your contracts, as Kelly said. Look at the list of that, of what you get paid, how much you get paid from each of those contracts, and how easy it is to take care of the people, right? The prior auth and all the other administrative burden that comes with it. And list that. And again, this is going to be in the next contracting series. I'm kind of giving it away a little bit with Kelly and Randy Bolt coming up next. But I think then you can really look at it and say, I can go to that payer, I can have a conversation, try to build a relationship, but I can walk away and I can be okay. I can take care, because I really believe, and I'm going to get on my soapbox and I'll shut up. But I really believe sometimes we're faced with whether we take care of our coworkers or whether we want to take care of all the community. And I think our PT hearts tend to go, we want to take care of everybody. So we don't say no to bad contracts. And I think, and again, I've been guilty of that. We're still guilty of that, I think, as a company. But I think if we all together did that in the same manner, I think we'd start to cause some pain on insurance companies that would make them come back to the table. Bob, tell me where I was wrong on that.
I think that's definitely right, and certainly not going to disagree with Mike publicly. No, just joking. It is something that I think is thinking about where you guys fit in the healthcare spectrum. I think is important. I mean, I think in the DC space we try to have a broader view. We don't always succeed, but really, you guys are not a very big spend for a lot of insurance companies. It's these huge surgeries that you guys are avoiding, and I think that trying to understand the insurance company's motivations is basically classic negotiation strategy. You want to be thinking about their interests and not their positions, and if you sort of put that perspective on it, it can be very successful. Having the data about how much your cost of care is really important to go into those negotiations. And then understanding, the insurance companies make money off of what's called tail. They take the money from the premiums that they're given, and then they invest that in the markets. So the longer they can wait to pay you, right, the more they're making off the float. So it is, I think, just sort of trying to understand their business model and trying to understand what they're looking for, I think is the right way to go. Quality is what you guys provide. I would say. And so it does get very frustrating when they bring up medical necessity and all this other kind of stuff. You guys know that, I would argue, better than the insurance companies do, but we're working on it and trying to put that more in your hands as a clinician on the ground, as opposed to some bureaucrat, answering the telephone. So I agree with Mike.
Vicki, was that helpful? Any follow-up there?
Yeah, definitely helpful. We are actually only in network with Medicare and one other commercial insurance, and we tried to renegotiate with that commercial insurance last year. And we made a lot of those points to them and sent it off to our your intermediary, or the person that we deal with for that insurance company, and pretty much it was just like, sorry, like no negotiation, just nope, it's not happening. So
Good for you, though,
maybe need to use more magic words next year.
I think it's good for you, Vicki, though. You're saying no. And again, we hear lots of people talk about it, I'm all cash based or I'm all insurance based, but the reality is we're all some hybrid of that. And I think it's much easier when you start in your spot, Vicky, where you say, here's what my care is worth. And I'm not settling for less than that than maybe some other of us practices who took everything and
Yeah.
now are trying to go backwards. Like that's harder, right? Or I believe it's harder. Maybe it's not. It's just my experience. But kudos to you. I think you're helping our profession by knowing what your worth is and not compromising that. So thank you for that.
Thank you.
And Kelly, I feel like you have something to add
Only
there.
thing I would potentially add is if next year you do decide to go back and you make that hard decision to drop the contract, if you haven't, get your patients involved because they're going to be really upset, most likely, that they can't access your valuable services. And our practice is in that boat right now and stepped out of network with a large payer. And that's one of the things we're doing right now. And obviously using it as a strategy too for our team, because it's hard to not treat your neighbor. That's really hard in a one-on-one relationship or one that you've had for multiple years as their care provider. So it has been really interesting to see patients advocate and let whether it be their benefit manager, their HR director, whoever it is at their employer, or wherever it is they get their insurance, know that they're dissatisfied. I don't know how that's going to go, but they're definitely getting the message so far. So we'll go back and reapproach this payer when a year comes up of being out of network. And I don't know yet what it will yield, but it's definitely causing a pretty big discussion in a smaller region.
And Kelly D in the group, I saw that you were asking about questions on strategies to negotiate. Is this conversation helpful, or do you have is there anything that you've tried that you want to bring up? Oh, just come off mute.
So, sorry for that. Tried a lot of different things. The business has existed for 45 years. And to Mike's point, the issue being we take everything, because way back, the thought process was don't make the doctors think about the referrals. Let them know they don't need a checklist of what insurance. So we take everything. So while that's great, we serve everybody in the community. We do have a large Medicaid population, which is they don't really want to hear. You can't. It's impossible to negotiate Medicaid and Medicare, especially because we're not just a outpatient practice. We're an ORF and a CORF, so we're an agency. So it's a little bit different with that. We're seen as a clinic, but I mean, I've done it all. I've tried to say how many patients we're serving, how many visits to their consumers, like tried that. But I feel like the end result in recent times is all the same, which is what Vicky said. And like, yeah, that's all great, but yeah, we can't do anything at this time.
Kelly,
Unfortunate.
thank you, Kelly. Kelly D, I'm going to ask Kelly, that's a clarifying question. I think many of us have done what you did, Kelly D. Like we want to make it easy for physicians, right? But again, our experience, but I want Kelly's experience too. Our experience is like physicians understand, they get it. They don't accept especially private practice physicians, like they get this world, right? So I think that was maybe a story we were telling ourselves as a practice that wasn't true, that they will stop referring anybody if we don't take everybody. But I wonder if anyone else has a different experience than what we've had in that space. Kelly Sanders, you guys,
Sure.
have you seen any drop in physician referrals from when you went out of network with different payers?
No. So yes, we did. So we went out of network in one state in July and the other state in November. And we did see a drop in referrals, but by January, we had record referrals. So there was a little bit of a decline initially, but now we aren't seeing that at all. And that was total referrals. The physicians actually, when we went to each physician and talked to them, to the same point Mike said, they understood. It was either I'm thinking of dropping it too. We are dropping it. I understand it's a really hard payer to work with. So we have not actually seen that. And we operated under that philosophy, like we need to take everything so that these physicians don't have to make a choice or differentiate who they're sending which patient to. And it just hasn't played out. again, I think there were a few reasons we saw a drop in referrals. One of them was in one state, it was 20% of our caseload. So it did hit us. But I will say that once we were able to educate, and I wish we would have gone and had those conversations with the physicians' offices. It wasn't that they weren't willing to refer. It was more that the patient was calling and getting an answer from us that we no longer accepted it. So we needed to work on our scripting a lot in that manner. And I will say that there was also some issues when we truly looked at our referrals, just what comes out of our EMR. You need to really dig into that because some of it was our front office. Our referrals, I don't think were actually down. They just had elected not to enter those referrals into the system because we didn't take that payer. So I only share that because I think some of the information you're getting, you really need to question even your own team to make sure your communication channels are clear and that the data you're looking at is actually accurate. And in our case, full disclosure, it was not. Our referrals look like they were down, but I don't think they actually were down nearly as much. We just stopped entering them as referrals into the system. So anyway, we've done very well. And then the other thing that I don't know if is always widely known, when you're dropping a commercial payer and a portion of that is Medicare Advantage, if you're still accepting Medicare, you can now, like in this case for this payer, we're still seeing that payer, but now we're getting paid Medicare rates out of network. So we're able to see that Medicare Advantage plan out of network at Medicare rates, which is about 20% more than we were accepting before, and we don't have to get off. So I just really ask a lot of those questions about what is it going to look like if I drop this payer? Do I have a Medicare Advantage component? What are the things I need to really strongly message to my staff so we can have good data? And that they understand how to have the conversation with potential patients calling and what options they have if we're out of network. So it's probably a little more than you asked or we're looking for, Mike, but that was our experience or has
I
been.
think that's helpful. I mean, we had the same experience when we dropped a contract in one market, and I think it took us less than 6 months to get back to prior volumes. And now with a better payer mix, right? So the payment per visit went up significantly because we dropped the lowest payer and ended up filling those spots with the better payers. So I think how much time that takes will vary based on your market and what's happening. The other thing that we've done in these cases is like we'll direct the patients. We can tell the physician offices, hey, still send them to us. We'll get the patients where we know they can get care and get it provided, right? So we can be that per people, but like you said, Kelly, it just takes process on your end to make sure your people answering the phone know how to direct people based on what the insurance is that they have.
Kelly, Nisha would like some clarification on what you said about Medicare out of network and Advantage plan. If you could just run through that one more time.
Sure. And this is another one. Bob, correct me if I say anything wrong. In our market, we accept Medicare assignment in the 2 states we dropped this commercial payer in, but we also had that commercial payer in a Medicare Advantage environment. So when we dropped the commercial payer, since we accept Medicare assignment, we still need to see that we can still see those patients out of network, but we get paid Medicare rates. So, just making up numbers now, these weren't our numbers. If we were getting paid a flat rate of $80 out of network, in network under our commercial contract for a Medicare Advantage patient, when we went out of network with that commercial payer, we could still see the Medicare Advantage side of that payer's book of business for full Medicare rates. And we don't have to get authorization in the 2 states that we have that we see those Medicare Advantage patients in. Prior, we were starting to need to get authorization under the in-network scenario. So
what's the impact on the patient for that, Kelly? Do they pay more?
So what we did before is we were able to get out of network benefits for a lot of them before we made that change. And there's only one tiny plan that has more patient responsibility. So their co-insurance or co-pays did not go up. They were the same. But I don't think that's the same in every market. So we did some research beforehand to find out what that was going to be. And then we still do verify their benefits so they understand what their out-of-network benefit is when we can get those. And we have not we have not seen, except for one small plan within that Medicare Advantage book of business that has a little bit higher copay. And I think I'm not saying this isn't a lot of money, but I think it's like $10. So we were able to retain most of those patients. Bob, is there anything else we should clarify on that?
No, I just reiterate a point that you made earlier, Kelly. This stuff is very linked to federal and state legislative advocacy, right? If you're trying to see Medicaid payments increase, you really can go to the state legislature. You really can go to the regulator. It's oftentimes the Department of Health, not the insurance commissioner, but each state is different. And so, we've seen and one of the other things I want to do today is just try to bring the good news, right? I think there's a lot of negativity about this is impossible. There's no way. We have Arkansas is now paying north of 100% of Medicare in their Medicaid program. Florida has seen real increases. There are success stories that are out there. And so us connecting you with some of those folks who have been so successful at it, hopefully we can be here to be helpful and they can as well. And so, yeah, I want to try to bring, the good news, like it said, that this stuff can work. It doesn't work on, immediately. And on the Medicare side, it can be very beneficial to tell legislators if you're a key contact or know your key contact from your districts or your states. I think folks are really shocked on Capitol Hill to learn that Medicare Advantage can pay less than Medicare Part B, right? They just sort of assume because more money is flowing out the door from the feds to Medicare Advantage plans that they're paying better, and oftentimes they're not. And so I think that communication strategy, that ability to let folks know what's happening on the ground outside of this DC bubble, really can lead to good results. And we're going to keep fighting that fight on the Medicare payment rate. But it's very valuable for legislators to understand what it's like trying to run a business when these rates are so crummy.
Agreed. And just to Bob's point, one thing we did when we did drop this most recent contract is we put out some handouts at the front desk for patients about just educating them on Medicare Advantage versus Medicare while we were still able to see them. It was very enlightening to just listen to their questions and direct them to some resources so they really understood the decision they'd made to take a Medicare Advantage plan and what the differences were between traditional Medicare and Medicare Advantage. So it was also just an opportunity to educate people in our community on that topic as well. And you never know who your patients are. That's been more apparent to me in the last year than ever. Like we were treating a state legislator. There were different things that were happening in some of our clinics or benefits managers. So you get the advantage of educating a patient, but also someone that may have a really loud voice in the community.
Andrew, I'm going to call you out to come up and elaborate on your question on how to deal with big insurance companies. So if you want to unmute.
Yeah, so kind of along the lines of what you're saying, basically we're a small fish. There's myself, I have another physical therapist in our clinic. We're a one location PT-owned clinic. And one of the challenges we have is there are a couple what I call higher volume clinics in our community. They take everything and we're much more selective. Definitely there's a lot of education that needs to be done. I have friends who are insurance agents and they're selling horrible plans to other friends and neighbors. And so I see where things are headed, and it's making it harder for us to continue to provide the care that we become accustomed to. And so, pre-authorizations, some of the things that you've already talked about as far as, when they have denials and we're appealing that and the take backs and all that, just it's getting harder and harder to try to keep up with everything. I still carry a full caseload and, try to run my business. And, last night I was done about 10 p.m. It's one of those things where I just feel like, I've been doing this almost 30 years now, and it just feels like that everything's going the wrong direction. And so we are trying to be selective. We've talked about trying to be cash based, but we're a smaller rural location where I just don't know that we could do a strict cash based practice. So I don't know what my question really is, other than I feel like that the insurance market out there is is crazy. I mean, I'll just use an example. When this poor CEO of the United Healthcare Corporation was killed, was murdered. I mean, I was horrified by that, but I remember just the next day thinking, I mean, sadly, this was before we even knew who had done it and why. And I said, sadly, there's probably a beneficiary somewhere that lost a spouse or was denied something and decided to take matters into their own hands. And I wasn't surprised. I mean, I have patients every day who are like, what? Like they don't cover this or they don't do that. And it's like, yeah, sorry. I mean, so I think I'm just trying to educate myself, what can we do as a small group to make a difference? And I do know a lot of legislators, but even they don't necessarily seem to be listening.
So I'm going to direct this topic towards Bob because right as we were waiting to enter, we were having a discussion. We use slightly different phrases, but I think I used shoulder to shoulder when we're fighting. And it's up to you if you'd like to share your term.
So, yes, I went to the LBJ School of Public Affairs, and one of his favorite quotes was, you want the folks who are more fired up to be inside the tent pissing out than outside the tent pissing in, right? So if you have some folks who are very active and able to harness that energy within the association, within the chapter, there should be within the chapter a payment lead, right? Someone who's interacting with these folks. That's a great way to try to get more volume to talk with folks, not just about direct payment rates, but about things like prior authorization, about things like what the insurance structures are like. We have a really great document that was put together before my time by a law firm on managed care contracting, and it has a side-by-side look of really good terms for you, really good terms for them, and where it might end up. And it can look a little intimidating, but those are also negotiable in some of these contracts. And so, again, probably a little easier for larger groups to do that, but you can have representation from other directions. And in terms of innovative strategies, not like what happened with United Healthcare, but one thing we did talk about also today was there's an article that we've been working on in CBS News online with Kaiser Family Foundation, or KFF, I guess now. And we had a PT in Maine, just telling stories about patients, and I think it's going to get a lot of pickup. I hope it is. And we have that author for the article, pretty much on speed dial, so we can try to get him to do some of that stuff. And then Stephanie's incredible expertise in social media, right? You guys are, again, much more liked than insurance companies are. And if you can work with local folks, if you can tweet out, if you have a Facebook page, all those things can really help you, I think, prove and differentiate yourself within the market, and prove that you don't have to be bashing on the insurance companies all the time, but you can be thanking them when good things happen, or trying to expose how hard it is for a patient X, Y, or Z. Obviously within HIPAA guidelines. That folks are really wrestling with the sort of things that happened in the United Healthcare case. There are a whole bunch of folks who know how bad it is. Pretty much everybody does, I think. And so, again, the public is on your side, I'll say.
Thank you. I think sometimes it's just nice to know that we're not alone. And so as far as our APT Idaho, I'm located in Idaho, as far as our payment lead, as you put it, they keep trying to get me to do that. I'd like to be more involved. I mean, I love that we have a private practice section and that you guys are doing things, and there's resources. I mean, I confessed on there that I haven't gotten in and watched the contracting series, and I need to. I mean, I need to educate myself. And so the challenge is, as with all of us, just the time and the energy to be a part of the solution and not part of the problem. But at least we're not just signing on to a bunch of dumb contracts. I mean, I'm proud of that. So
yeah. And I think that's the first step that you're doing. That, again, I'm going to throw myself in the bucket of people that aren't doing that. We have too many bad contracts that we're still part of, and we need, as a company, find a way to do better. Because I think only if we do this collectively will we have an impact, right? Again, it doesn't appear, even with any of the large practices, that they have, like, no one has enough leverage in this space to tell the big insurance companies what to do, right? But I think collectively we do. But we have to use the same methodology. We have to be disciplined. The most optimistic thing I can say is our secret's out, right? You might have seen that article actually with that headline that came out, but the demand for what we do is a lot greater than the supply we have to do it with, the coworkers we have to do it with, right? So economics would say now is the time where we get to change price if we choose to, but we have to choose to. And again, that's going to involve hard decisions of saying to our neighbor, I'm sorry, I can take care of you, but just not with the insurance you have. It looks like this instead of that, right? It's not that you can't take care of them. It's just, it's going to look differently. And I think that's what we're trying to do with the contracting series. That's what we're trying to do with those of you who are boots on the ground at your state or in the federal advocacy. And then PR. Bob mentioned PR. Like I heard there was a practice owner in Louisiana I heard about that had a wonderful tagline that she sent out about an insurance company that sounds like human, but it's she, her thing. I think I could say this, Bob. Can I say this? Like it's happened. I don't think this is any collusion, but her whole thing was she had a bad experience and she just had a little tagline that said, "You would think there would be a human at Humana," and she sent that out, and suddenly Humana called her and said, "Hey, can we talk about this? We don't like that this is out there," right? So again, that is how a combination of a PR strategy coupled with a very thoughtful strategic strategy at state, federal, and then individual level as us. But none of that other stuff's going to matter if, as practice owners, if we keep taking bad contracts. I think that's the fundamental thing that we have to do. And again, I am guilty. I'm not casting stones here. I live in a glass house, so I need to take care of my house first. So
I'm going to switch gears a little bit, and we have a cash-based practice in the group. I think we have a few who are cash only. So I'm going to direct this at Kelly. We talked a little bit about alternative models, D2E, combining partial insurance, partial cash. So this question came from Paul. If you want to come up and jump in the conversation. But Kelly, if you want to start with anything around alternative models.
Sure. So I think Mike touched on it already. I think all of us have cash pay businesses to some degree, and I think that's an important thing to look at. I know just as we've started dropping contracts in our business, and we too have a long way to go. It's really a little bit overwhelming to some of your team members because they're like, we're not a cash practice. But I think if you just start having the conversation that we all take cash just at different levels. Some of us are 100%, some of us are 50%, regardless. So I think if we can be open to that and take away some of the misunderstanding there, that's helpful. In terms of alternative options for payment, we do have those. So probably the largest one that we've been pushing at APTA Private Practice is this direct to employer idea. And we do have a great direct to employer series that you can go through. It is changing and it will all be asynchronous now. Instead, there was an in-person component that you had to be able to fit that date into your calendar. And then there were 2 modules that were asynchronous. Now they will all be asynchronous. So I'd really encourage you to do that. It helps all of us by getting more people to go through that certification because we do post on the website those that have gone through that training because we've had different stakeholders in that space ask us and say, who are the people that understand direct to employer? Where are those practices located? I have employers that want to network with them. So the more we can build out that network of people that have gone through the series and have some education or experience in that area, the better. In that series, we do educate practices, and I wouldn't do it justice to say all of it here on this call, but we go through a few different things. One of them is just how do you approach an employer and what is the conversation? What are the questions you should be asking? And most importantly, what is the listening you should be doing to try to find where they could benefit from your services? So the first part really goes through how to approach potential clients in the employer space. And then we do go through some of the specific contracting components as well as the legal components. But I would highly recommend that if that's something you want to step into, because I think a lot of us have failed in the direct to employer space, in my opinion, because maybe we haven't asked the right questions. But again, maybe we haven't listened to what their problems are, and we've just gone in and said physical therapy or my services can fix your problems. And we make a lot of assumptions in approaching the relationship that way. So that is probably the biggest thing that I would say on the direct to employer front. But we've had the opportunity to personally be in a few of those contracts. It is very liberating. There isn't pre-auth in most cases, and you can make sure that happens. It was very novel for our accounting team to just send an invoice. They're like, doesn't this need to go through medical billing? I'm like, no, we just send an invoice and they're going to pay us. And they're like, right away? I'm like, well, whatever you put in that 30 days. But so I think that's really great. And the problem solving you get to do as a clinician is really exciting because you're making a difference in someone else's team members. And I know every private practitioner I've had the opportunity to meet takes a great deal of pride in the team that they have and their team members. And to be able to help someone else's team member and save them money, but also have them have better outcomes has been really rewarding. So I would check that out. If there's specific questions about direct to employer, please let me know. I'm happy to answer those. But it does look like going to large employers, going to small employers. We have one that has like 6 people. So there's a lot of different things you can do in that space, and work with businesses in your community to try to help them with their MSK needs. And I think there was another question on I think I missed it. Sorry. There was one I saw. I think it was, I'll scroll up.
There was a question on how going out of network affects reimbursement. Before you jump to that, because 2 people had questions on the direct to employer, so I just want to give both Paul and Karen the opportunity. If you want to ask anything else, come off mute. I know sometimes it takes a second and I don't want to miss. Okay.
Can you hear me?
Yes.
Yeah, so I'm just curious about that director employer. That's a program that's available for purchase from the PPS, correct?
Correct, it is. And if you have specific questions, we're happy to entertain those now as well. But yes, we can put that link in the chat too. I can as soon as we move on to the next topic for sure.
I think
Oh,
one
thank
point of-
you.
I think one point of clarification, Kelly, sometimes when SSPTs hear direct to employer, we think work comp. It can be, okay, but this can also be just general musculoskeletal, right? So this is just a contract that employer X pays us X amount per visit, and we just skip the insurance and go straight to them. I mean, there's many thousands of models, but just I wanted people to make sure they expand their horizon. This is general health as a whole, not just work comp that we're talking about.
Great point. And a lot of times you're not even taking care of the employee directly. It's their dependents for maybe a self-funded or self-insured employer. They're just looking for a way to decrease their commercial insurance or what we would traditionally consider commercial insurance costs. And they just directly contract with you for PT services as part of the plan that they offer to all of their employees and their families.
Yeah. And I think I've been on this soapbox for a while and I'd love to be wrong. But I believe it's only the people that pay for healthcare that care about how much we save healthcare, right? And the people that pay for healthcare are employers and our patients. Insurance companies get to make, as Bob said, they get to make 15% of whatever their premiums are. I'm not sure why they don't want their premiums to go up. Okay, so I really struggle with that perverse incentive that is built into the system. But I do know self-insured employers who are paying the first 100, 200,000 of claims would love for those claims to be less. And that's where coming to your team first before they go to convenient care, urgent care, the ER, the ortho, they get it. They see that boy, that's a lot less money. And so all that cost saving information we have, the value of PT project, thing, that's who it resonates with, is the people paying for healthcare.
And
Right, I'll just share. Oh, go ahead.
I was just going to say, as an out-of-network provider, when I learned about the D2E program, I immediately thought of how we work with the local colleges or dance teams or athletic programs to offer injury prevention. And that is something that a cash-based practice is very familiar with, right? But this is kind of just an expansion of it and a different way to provide injury prevention in this setting.
Absolutely, Stephanie. I see a question from Mark here about small outpatient PT, shed some light on hospital paid versus private practice. Again, why do hospitals get paid more than we do? It goes back to that leverage thing that we talked about, right? You see this every time. It's like the Super Bowl anytime the Super Bowl comes, your cable company's about ready to drop that channel. And so they get in this little leverage negotiation standpoint right around the Super Bowl. The same thing true with hospitals. You're seeing it more and more play out in the press. So because those insurance companies need those hospitals in network in order to sell insurance, those hospitals have a lot of leverage in negotiating the higher payments. So where you use this with price transparency now being required for hospitals, you can take that, what the hospitals get paid versus what you want to get paid, and you can take that to these employers who are actually paying the costs for that, especially self-insured employers, which is usually more than 100 employees, is a good ballpark to use if you're wondering in your neighborhoods who might be self-insured. Now you can take and say, hey, you come to me, I'll take $120 a visit or whatever you think. If they're going to go to the hospital, it's going to be $500 a visit. So do you want to contract directly with me? And we'll be happy to take care of all of your coworkers, their families for this rate, versus if they end up in the hospital, they'll be paying this rate. So we can turn that thing, which we don't like, to our advantage now through some of these vehicles that Kelly was talking about.
I come back to Jessica's question on out-of-network reimbursement. Kelly, if you were going to answer that one.
Yes, I think the question was what does out-of-network reimbursement look like, or does it change your reimbursement? And I don't like this answer, but it depends, I guess. So
what else did PT say?
Yeah. So what my experiences have been, and Bob can maybe add to this, is that it depends on the particular payer, but then within that payer, it also depends on the plan that particular patient has. We've had patients not have out-of-network PT benefits, so they're coming to us as cash at that point if we don't accept their insurance in network, or we've had them have exactly the same benefits, and our payment would be about the same or better. So we've seen it very widely in the commercial space in our markets. And sometimes we've tried to do a lot of research when we're looking at contracts. We have our verification team pull plan numbers, and then what the benefits are in network. And if we can get them out of network, we do. They won't always quote those out of network, is what my team tells me. So we try to collect a lot of that data and understand that before we make that decision, if we can get it. And we like to keep that data, so if we do go out of network, we're aware. But my best answer is it depends, and try to do your research on that, or ask your patients, because they can get that information, obviously, and sometimes they're willing to share that.
Yeah, and Stephanie, if it's okay, I think patients generally don't know what their benefits look like. I mean, I think it's until they really need it, they've not read any of this stuff. The HR department really hasn't negotiated effectively. It's just this stuff is complicated, I guess. And there was an earlier question on marketing resources, and I'm popping something into the chat on that. I don't think we have an exact thing about specific insurance companies, but it's probably the best that we have on our website. And I would be completely remiss if I didn't talk about the State Payer Advocacy Resource Center that we put together, really Mike's baby, and a whole bunch of other leadership. That is basically a joint consortium between the private practice group, the orthopedics section, and then additionally APTA generally. So we're really trying to coalesce and get more economies of scale, more volume of advocates. And this is where a whole bunch of resources on appeals and denials, there's great stuff on contracting strategy, just a whole bunch of areas. And we have goals for this that we're going to try to move forward with for 2025. We're going to try to get more resources out there for you. This is a great idea on marketing to specific insurance holders and what that might look like, see if there might be something valuable to that. We've also talked about cash pay resources that we might try to put together. But what's been the biggest innovation is that APTA is absolutely on board with this. At CSM this year, they announced that they were going to be housing all of this material on the APTA website. We used to house it in the past, but it's a great thing to expand our reach and really get more attention paid to these issues within the association. So I would really recommend you take some time to, if you can, take a look at those. We've got sample letters. We've got a whole bunch of resources explaining how the MPPR works. We're, really filling out all those resources. So if there's anything else you need, also, you can always contact us. I'm happy to do case-by-case work. In fact, it's one of the things I do every single month in terms of helping specific practices with direct questions. So we're here for you.
Right, so everyone knows that those resources are in the chat if you want to grab them. And we'll also be sending out these resources at the end. Any other questions? I'm looking at, there were a couple that came in ahead of time. And for next month, anyone who comes to the leadership, if you can send your questions in ahead, it helps so much, just help us for us to prepare. Okay, one of the pre-submitted, I don't know if we covered this, but I'm going to bring it up again. How to fight insurance clawbacks without using ERISA. Is there any guidance?
I'm happy to start. I think the mantra is appeal, 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 right? It is amazing how complicated appealing can be, but it shouldn't be. And I think part of the reason the complications exist is because nobody does it, right? There was a great Kaiser report on, I think it's more than 90% of denials just get, nobody appeals it, right? But there are multiple levels of appeal, internal appeals, external reviews, that we've seen success in PTs engaging in. And so there's at least, so one practice in Georgia or South Carolina had 21 clinics, right? So relatively medium-sized, not enormous. They had one admin who just was assigned to appeal every single denial. And they saw amazing results from the insurers finally saying, hey, what is going on here? We're denying these things, and we keep getting hit with these external reviews. And the sort of unknown secret, I would say, about external reviews is, at least in some states, the insurance company has to pay for the external reviewer to take a look at the denial, right? And that can run them $1,000 a pop, right? So if you really want to start getting them to pay attention and stop denying all these things for medically necessary services that you know better about, you can go through that process. It can be complicated, but it really shouldn't be. And I think it's important to recognize that nobody does it. I think once you get to that external, I think 2% of denials go to external review, but it is a right the patients have. It's a right you have. And in terms of clawbacks, I'll also say that there's been some good success in Montana for this exact issue. They had across the board denials, clawbacks that they were trying to implement, and they just pushed back and appealed and appealed and appealed, and they won, right? Those clawbacks all went away. So you do have rights here. The patients have rights here. I read those letters that come in, and then, contact us if you need. Happy to help with strategy or other sorts of, ideas that might be helpful in those contexts. And also there's other PTs who have been successful we'd be happy to connect you with.
If it's okay with Stephanie, do you think you could go into a couple of the things Spark is working on, just in case people don't get to the website, just so they know
Sure.
all the work you're doing with Spark to get these things accomplished for membership?
Absolutely. So, like I mentioned, the orthopedic section has about a large membership, 17,000 members. I think it might actually be the largest of the sections. We have about 4,000 in private practice. So we're trying to, and there's a little bit of overlap, but really we've started sending out advocacy alerts and requests from the combined membership. That's one of the first thing or most recent things we've done. But generally what the consortium is broken into is sort of three main goals. right? The first thing we hear about besides payment, and of course payment is critical, is administrative burden, right? We just see so many folks having to fill out so much dumb paperwork, and so we have a whole bunch of resources on prior authorization, on appeals and reviews, like I'd mentioned, and we're trying to provide more resources. I think overall we're shooting for more than 20 new resources for you, videos, one-pagers, letters, et cetera, that you can use and modify, and then contact us if you need to help you with submitting. Then additionally, there's just straight up payment, right? And we can't negotiate payment rates for you. And sorry, Archibald is in the background. We can't negotiate payment rates for you. But we can help with strategy, right? And we certainly can help with ghostwriting letters. I've done that for a number of practices, and differentiation. I had one solo practice I think it was in Seattle, who was trying to figure out how to get this one payer to respond. And we just sort of talked about, well, what are you different? How are you special? And he, was highly certified in wheelchair fitting, right? And so by being able to sell himself that way, he got in network. I don't know what those payment rates were like, but that was a big goal of his. And so then you work on the payment rate, right? So it is possible for small practices to work on that. Finally, one thing that I was sort of surprised at, but I'm really happy about as a former Medicaid advocate, is really that we want to see Medicaid working more effectively across the country. And it seems to be that we're making some progress in some states, but Medicaid is a slow payer. It's a low payer, lots of paperwork. A lot of folks just don't take it. And that's a reasonable business decision. But I think folks would want to take it if it worked more effectively. And, again, amazingly, we've seen states that are paying better in Medicaid than in Medicare, which I think just turns the world on its head. If we can get Medicaid to pay more effectively and decrease that administrative burden, why not take it? Right? It seems to make sense to have better payment streams, a different case mix or a more robust case mix. Andrew, I think that's what you probably focus on is case mix. Just joking. It's an opportunity I think that a lot of folks don't really think about because it doesn't work very well in lots of states. So anyway, those are the three main areas we're focused on. I think we've made progress in each of those areas. And like I'd said, one other thing that I want to try to get out there as much as possible is this multiple page side by side or proof of concept of all the wins we've had, right? And not just stuff that is specific to Spark, but trying to educate and persuade y'all that some of this stuff actually works when you do it. So takes time, takes energy, takes effort. We're here to help. And I think it really can make a difference in your practice and for your patients. And then, as Mike said, you can take care of your colleagues as well as your community, which is really the goal here.
Bob, I love that you talk at a New Yorker speed. That was,
and I'm from Texas.
Mike, Kelly, anything you want to add on before we wrap up?
I don't have anything else. Just thank you. I'm excited to see so many people interested in payment, and Bob really means it. He's there if you want to reach out to him, and he has created some amazing resources. So please use them and use the resource of Bob. We are very lucky to have him.
Yeah, thank you. And again, I will just reiterate what Kelly said. This is I am encouraged by some of the progress I'm seeing from practices of all sizes. Bob, you mentioned about the wheelchair fitting. Again, somebody talked about strategy negotiation. I've heard other small practices just get raises because they asked. Again, so even the simple things of just going back and asking, if that's not something you have as a regular hygiene for your practice, is to go back and ask. And sometimes, again, some justification is a small niche. I think people do things for people they like. And I think if you have the ability to generate a relationship with somebody at the payer, which they try to prevent by moving people around, I understand they have a really good strategy to kind of keep that from happening. But if you can go back and ask, and sometimes the niche practice, I do vestibular, nobody else does, or I have a pelvic floor, niche that is not served in this community. Sometimes those are the reason or excuse that payer can bump up your payment by a few dollars. So keep asking, keep trying, keep doing the great work you're doing. And I think because demand for what we're doing is so great now, I think if we do this very thoughtfully, intentionally, moving forward, I do think I think the time has arrived for us to make a difference in this space. So I appreciate all of you engaging in that conversation.
Thank you, Mike. Thank you to our panel, Bob, Kelly. Thank you for everyone who participated today. If you have any follow-up questions, you can send an email to info@ppsapta.org, which I think Kat is putting in our chat. And Seth, I saw that you snuck a last-minute question in there. We get the chat when we get the recording, so I'll make sure that we get you an answer. Any of the resources that were listed in the chat, we'll make sure it gets out to everyone. And this series, Beyond the Treatment Table, is every fourth Thursday at 1 p.m. Eastern. Next month is my favorite topic, leadership. So I hope you join us. And May, we're going to have operations. June, everyone loves marketing. So just plan to spend a lunch hour with us every month. If anyone has 2 minutes to stay on Zoom, we're asking a couple questions about feedback. It will take 5 minutes or less. Just hang out as everyone else signs out. And thank you.